What a gift to be with all of you today. I like to say that I speak from my heart, and the topic that I am looking to present to you today really is something that I am very passionate about. I was thinking about my time in the healthcare systems, and I was wondering, do doctors still ask to have their pictures put on billboards?
Yeah.
Yes, they do.
Kind of like that. Yeah. Does that guy look like anyone you know? Yeah. Anybody know this Dr. House? Yes. I chose Dr. House on purpose because, does anybody watch that? Who watches House? Joan? Okay. I actually just started watching House earlier this year, and I chose him because he is this master diagnostician when other physicians could not find the answers. And it's very reflective of the type of stories that I would hear from patients on my podcast, the Desperate for a Diagnosis podcast. So I'll tell you a little bit about my why. Why did I start the podcast, and why am I so passionate about this message about being undiagnosed and unhealed and misdiagnosed? And I would bet you, any of you either have experienced this yourself or you know someone who has gone through it. And healthcare, working in the healthcare systems, from my opinion, taught me the business of healthcare. The market research interviews that I've conducted over the last over 9 years have taught me about the heart of healthcare in so many ways, because I interview doctors, patients, caregivers on a daily basis. This is my work. I work mainly with pharma and other type of healthcare companies, but I heard time and time again, I saw 6 doctors, 7 doctors. My doctor dismissed me. My doctor, I think he thinks I'm probably crazy. He thinks it's all in my head. I would bet you that some of you either experienced this or know people who have. So this is my why. This is my passion for elevating the healthcare experience, the human experience, and that's why I'm happy to be with you today. What we're going to talk about is a few things. What it sounds like for patients who feel dismissed. I'm actually going to be sharing clips with you from the podcast so that you hear these lived experiences from patients who have gone through the system for several years, many specialists, many doctors. Some are still looking for an answer. I also will present perspectives from both sides of the bedside. I have been fortunate to be able to interview physicians on my podcast and ask them questions that I would have never asked had I been still working in the healthcare system. These are conversations that I believe we never get to talk about in the healthcare setting. It's a conversation that I believe is either that elephant in the room or this underground patient journey that we never really think about. And it does happen. So you will hear from both my patient and physician. Yes. How does lack of trust in undiagnosed patients factor into the bigger picture? And then some tips and some ideas on how marketing and public relations may help rebuild trust and influence the trust conversation. So let's talk about being dismissed and delayed and what that means. There's nothing wrong with you. These are the words, again, that I have heard from patients that I have interviewed on my podcast and in market research, who walk away with either hearing these words, or they may hear these words from friends and family when they don't feel well, they don't look sick. In fact, there's a book called You Don't Look Sick. And yet they're feeling incredibly dismissed, unheard, and I will share some of that with you from the perspective of one of my podcast guests. And we're going to start with Charlene.
I sent him an email and I said, "You're not going to believe this, but I think that the surgical site is opening up again." And he said, "It can't be. Just go home, relax, and take a warm bath." He didn't believe me. This is something called medical gaslighting that we talk about in the book.
Charlene was referring to her brain tumor. She had a brain tumor removed and surgical site was opening. She contracted an infection in the bone in her skull and had to go to a plastic surgeon to have that part of her skull removed and replaced with a titanium plate. Eventually, she went several times back to the plastic surgeon who kept stitching up her surgical site because the site just was not closing out. She went back to her neurosurgeon who did surgery, and he said, I knew nothing about this. 6 months had gone by, and the neurosurgeon had no knowledge of what had taken place. So not only was Charlene feeling dismissed, there also was no communication with her physician. Charlene is a human resources professional who teamed up with, this is Dr. Colette Edwards, who we will hear from, and they wrote a book together called Navigating the Healthcare Journey, Lessons Learned to get the care you need and deserve. So that's a little bit about Charlene. Gives you a flavor of what this dismissed language sounds like. Next, I'm going to introduce you to Dr. Alan Rapoport, who has some perspective on this patient journey of being dismissed.
She kept telling doctors, I'm dying. And whatever doctor she went to, they examined her. They didn't do enough. He ended up being put in a psychiatric ward. And the psychiatrist knew me and said, before I totally treat this patient, I want you to evaluate this patient. I started asking questions, and I said, are you having any trouble breathing, everything, chest pain? And I listened to the patient's back, and there was something funny going on in the lung. We did a chest thing. I go to the radiologist, and they said, there's something going on here. She had a hidden cancer deep down in her pelvic area, probably her ovary. When you have a hidden cancer like that, you get a little growth on a valve in your heart, and it can flip emboli to every organ in your body. It was going to her brain. It was going to her lung. It was dying. We said to her, you're right. You do have something major wrong with you. So even a patient who says they're dying and people miss things and they are in fact dying, you gotta be quite careful about that. Intensive therapy, which of course wouldn't have worked because it was not what she needed.
Is that shocking at all, or is this something that you feel happens in healthcare? Yeah. So it does happen. Dr. Rapoport, he's a renowned neurologist, he's a headache specialist, travels all over the world talking about headache medicine. And I was honored to have him on my show twice. And the second time, for an hour, we talked about patients who feel dismissed. They use the term medical gaslighting, and this was some of his perspective. But it does underscore how even a patient who could be an advocate, such a strong advocate for themselves, knowing that something was wrong, and to even go so far as to say, I'm dying, that a physician would label a patient as being a psychiatric patient versus her having something truly physiological happening to her. These are some of the other words that I've heard from patients that I've interviewed, and some interviewed not only for market research, but also for the podcast. You don't look sick. It's all in your head. It must be anxiety. Your tests are inconclusive. And even if these words in particular aren't the ones being used, there are patients that are walking away with this feeling as if a physician implied these things. And again, these are also sentiments that people will hear from friends, from family. I heard time and time again in market research, well, I had to stay home because I didn't feel well. Maybe someone had lupus or some autoimmune disease. I had to stay home. And people would say, what's wrong with you? Why do you have to stay home? I'm fatigued, I can't get up, I can't get out of bed, I feel nauseated. Well, you don't look sick. So these are the things that people do here when they do have undiagnosed disease. They're underdiagnosed, undiagnosed, delayed diagnosis. It all kinds of fits in the same bucket there. But patients are constantly swirling through the healthcare revolving door. I think the revolving door is very much how patients would describe their experiences seeking out a diagnosis. Medical gaslighting. There's a few different definitions out there. This is the one I use for our purposes today. I think it's very common in terms of how patients who have gone through this type of scenario would describe medical gaslighting. It's from verywellmind.com. Medical gaslighting describes a behavior in which a physician or other medical professional dismisses or downplays a patient's physical symptoms and attributes them to something else, such as a psychological condition. There was a small U of I study that was conducted with 36 women, ages 21 to 70. And it was qualitative research, so they were conversation interviews. And what the professor of communications and the graduate assistant deduced from these interviews is that women's concerns are not taken seriously. This happens a lot with women. It happens with marginalized communities. How many times have you heard the story about the woman who goes to the ER with what seems to be heartburn that ended up being a heart attack? How many times have you heard the stories about the patient that went to the ER because they were in pain, but there was some bias that told the ER physician that this is just a junkie, someone looking for pain meds? Those are the kinds of things that this study had investigated, although small. But women in particular felt dismissed, isolated, and so many of them felt like they were not even worthy of getting care. And many of them gave up. And many patients who are in this type of patient journey, they do give up and they quote, live with it, because either they decide to live with it or their physician said, I have no answers for you, live with it. Some other quick statistics here. She Media survey did a survey of women. 72% reported medical gaslighting. Again, patients feel or are seen as unstable, irrational, not credible. And I think, who's heard of the white coat syndrome? Do you have them? So there's this interesting imbalance of power that happens in a physician's office. The physician is the all-knowing doctor. You are the patient sitting in the gown. There's this intimidation factor that kicks in. You think you're very prepared for your visit, get it all figured out. I'm talking to the doctor about this. The doctor walks into the room. What happens? They just need one little trigger that tells you they're too busy. They can't listen. They're busy charting. And you forget everything that you wanted to say. These are the things that happen in the doctor's office. And I can recall working in the systems and working with the medical groups. Our jobs as marketers and communicators are a little different from that standpoint. We're looking to grow business. We are looking to build referrals and loyalty, retention, and all those things. But to really understand the true experience in the doctor's office is really a gift to be able to really dig into and understand. So I feel very fortunate that I've been able to experience those conversations. From Every Life Foundation for Rare Diseases, and that's where it's really hard to find a diagnosis in some of the rarest diseases. It takes over 6 years and nearly 17 medical appointments, visits, etc., to get a rare disease diagnosis, and I would bet you it's even more, depending on the disease. And I will share with you a clip from one of my podcast guests who actually saw over 30 physicians until she got a diagnosis for her rare autoimmune disease. As we talk about trust, doctors do score high for trust, but the trust factor is declining. So in 2024, doctors rated lower than in 2021. So from 67% to 53%, and the metric was honesty and ethics. So it's still high, but they're on the downside. Nurses rated higher. I don't have a number for you, but they rated higher. But this is just perspective from this Gallup poll. A question to ponder. Have you ever felt dismissed, either with a physician or maybe just in your personal life? And think about how that factored in on trust. How did that impact trust? So let's get behind the charts a little bit more. This is Laura. 10 years ago, she was in a car accident, which started this cascade of symptoms. And let's hear her story about being undiagnosed.
But I went to a lot of medical facilities, upwards of 25 doctors.
What kind of doctors, Laura, did you see or were you seeing?
Primary care, of course. They sent me to rheumatologists. They sent me to a gastroenterologist, lots of tests for that. Neuromuscular doctor, a neurologist. And I think that's pretty much where it ended, because they all said, all your tests are normal. There's nothing wrong with you. And at one point I changed doctors, and it never even in a million years occurred to me that they did not think my issues were legitimate. Like, that would never have been a consideration for me. I just thought they weren't being very helpful. And the doctor basically let me know that it had been noted in my file that these symptoms were psychological.
So I still talk with her. In fact, I just talked with her this week. She is still seeking a diagnosis. Unfortunately, she has deteriorated terribly. She is now walking with a walker. She is highly fatigued. She has been able to get a few diagnoses, one being Ehlers-Danlos, which is a autoimmune disease that affects muscles, bones, could affect your heart. She also was diagnosed with POTS, which stands for postural orthostatic something syndrome. It's a whole long name, but it's when you stand up and your blood pressure isn't regulated and you can pass out, you can get fatigued. So she does have some diagnoses, but she still does not know why she is deteriorating so terribly. She is at the point now where she has to decide, does she quote live with it? Does she go to a functional medicine physician? And when you go to functional medicine, it's out of pocket. She is at the point of potentially draining her bank account because of having to pay fee for service, all cash, to try to fight a diagnosis. This is Dr. Gary Simmons. He is a highly skilled neurosurgeon who is a professor. He's a contributor to Psychology Today. And he's also an author of a fiction book called Death's Pale Flag. And who knew there was a genre called medical thriller. So he writes medical thrillers now. But Dr. Gary had a very similar situation. And he's a physician. And he reflects on how he, as a patient who knows how to access the system, still stopped and asked himself, am I crazy? Is there something wrong with me? Am I nuts? He was gaslighting himself.
So for the next few days, I had lumbar punctures and MRIs and PET scans, and nothing was really showing up, although there was all these weird spots in my brain. And actually, to be honest with you, Laura, to go back to what we were saying before, one of the things that was playing in my head at the time was, am I just a nut? Am I a psycho? Is this all psychosomatic? Is this psychological? Because nothing was being obvious. And it was weird because seeing the spots in my brain was comforting, but a weird sense, because it was, oh, something is going wrong, but at least I'm not crazy. At that point, we still didn't even have a name. We just knew they were out of unidentified brain objects. We call them UBOs. But there was something going on.
So when a physician can't find an answer and he's questioning himself, a neurosurgeon, no less, who has the best access, the best of access to specialists, to getting in quicker. He knows how to navigate the system. Even he was wondering if he had something wrong with him from a psychological standpoint. Dr. Gary eventually did get a diagnosis, some type of encephalitis that eventually required him to move away from the table. He had to retire. However, he did say, it made me a more compassionate, empathic physician. And I think until really any of us go through a situation, it's really hard to empathize. But to hear it from a physician, again, was really a gift for me to be able to talk with him about that and for him to tell me his encounter with the healthcare system. And there are a lot of books out there that are about medical gaslighting, about being dismissed, that are written by physicians who have been dismissed themselves. So it's fascinating when you hear their perspectives from the other side of the bedside. The physician's point of view, again, I was able to ask these doctors questions that I would have never considered asking while working in the systems. We're rocking and rolling as marketers and communicators, talking with doctors. Doctor, I've got this campaign, I need you to sign off on it, talking to the director of the department, and what do we need to grow, doctor, and why are we better than the guy down the street? I remember all of these conversations. But to be able to talk with a physician about what really goes down on the units, on the floors, in the departments. Dr. Joan Naidorf is an emergency physician who, emergency room medicine is very interesting because they are the entry point for people for all walks of life. They really get to see what the real deal is of the world and what's going on. And their job is to either fix you so you can go back home and get in touch with your physician, follow up, or get you admitted. Everything else in between, they are not equipped for. So patients who find themselves in a position where they can't find answers and give a name to their symptoms, they go to the emergency room. And that sucks down the resources of the hospital because they're going to the hospital unnecessarily. You know, all those times that we talked about, how do we keep patients out of the ER and going to immediate care or urgent care? Do we fast track them? Whatever it might be. There are just some cases that you just will never be able to fast track because these people don't have answers. They're either in pain or they're vomiting or whatever it might be. What's your recourse? They go to the emergency room.
When they come in announcing what they think they have already, or some words appear on their chart from somewhere else. Someone has written words on their chart like non-compliant. Sometimes patients are starting out with their nurses and doctors having a bias against them. Mm-hmm. Or it could be the words that they've used at triage that are placed on a triage note that is actually causing some non-curiosity by their physicians. If the physicians and nurses think they already know what's going on with you, they're going to stop asking questions. The nurses and physicians tend to rush to a little bit of judgment, and we're not even thinking about maybe the 10 other things it could be. We're looking for the most common things are still most common. I think this is why people tend to get pushed into certain diagnoses rather quickly.
Is this surprising anyone at all, that this is what happens in our medical systems now? Patients who have been dismissed, medical gaslighting. I said, I do feel like this is either the elephant in the room or this underground patient journey that just does not come up. We love talking about the new procedures, the rock star doctor, the outcomes, but we never talk about the diagnostic journey for patients who have had a hard time finding a name to their symptoms. How much does burnout come up as a conversation in your systems? Anyone have that come up? Anyone talking about Dr. Burnout? So I was at Chicago Health Executives Forum meeting just last week. And it was a panel. And one of the panelists was a physician who was in charge of innovation. And he said, because of AI, we were able to help physicians free up time. But we freed up their time so that they could see 11 more patients. not so that they can have more time with the patients, but to see more patients. Counterproductive. So doctors are burned out. They don't have enough time. 15 minutes maybe, does that sound right? Is it, or less? 7 minutes? Half an hour for new patients maybe? Yep. So he talks a lot about burnout.
If you're seeing bad behavior from your physician, a lot of times it probably is they're burned out. But it doesn't change the fact of the patient's experiences can be far from ideal. First of all, the time given for each appointment is short. It's gotten shorter, particularly as more physicians work for these big mega systems, got shorter with all the computerization as well. And so they're always in a hurry. It's always easy to blame a system, and it has got a lot of reasons for it to blame, not to paint them as evil, because they're the ones that have to interface with the government and the insurance companies and the lawyers. But it's just more barriers. We become hostage to things like what they call RVUs, which is how they rate the amount of work you're
Productivity.
doing. And it does end up scrunching the amount of time that patients are given and the amount of personal say that the patients have.
So these are the real things that are going on in the offices with patients who don't get enough time with their physicians. So there's a variety of reasons why patients may feel dismissed, that they don't understand about how the system works. And quite frankly, patients don't necessarily care how the system works. They want answers. They want their doctors to listen to them. They want a collaborative relationship with them. And all those things factor into why patients may feel dismissed. Time constraints, physician burnout, unconscious bias is what Dr. Naidorf talked about. Complex diagnoses, much like my podcast guest, Laura, who's still seeking a diagnosis. Communication gaps. Maybe doctors just aren't explaining the diagnoses very well, or how to use the medication, or the side effects. There's health literacy issues. There's social determinants of health that don't allow people to really understand what their doctors are saying. Knowledge gaps. Doctors have so much variability in terms of their training. So if we go back to Dr. Rapoport's statement about how one doctor thought that the patient who claimed she was dying was actually a psychiatric patient, and she actually had something physiological involved with her. So even as much as that advocating that patient did for herself, she still could have ended up on a psych unit, getting psych meds that wouldn't have helped her because that wasn't an issue. System limitations. Of course, there's insurance. A lot of this, sometimes the roadblock is insurance, but then there's restrictions in testing and treatment. Again, insurance, we can only do so much about, but patients don't always understand how their insurance works. We are all in healthcare. How many of us really understand how our insurance works? And sometimes the physicians just don't know. And then the patient has to move on. I had a desperate for a diagnosis moment. I've had a few. One in particular, after I had seen my primary, I saw a neurologist, I saw a few other specialists, and my primary said to me, I have no more bright ideas for you. If I was someone who didn't know how to navigate the system, I would just have been living with the symptoms that I had been experiencing at the time. Luckily, I know how to advocate for myself and push to get the answers. Some implications of being undiagnosed and misdiagnosed and having a delayed diagnosis. So I think pretty obvious, talking about patient trust. This all factors into the trust factor. Trust is subjective also. So to try to really figure out what a patient is looking for and how they define trust is very different across the board. However, they want to trust their system, however it works for them, whatever it means for them. If they're in this patient journey, this diagnostic odyssey, as I like to call it, they are going to have trust issues and potentially leave your system and go to other doctors. And then, of course, retention, reputation, and growth. Patients are talking to each other, they're talking online. How does that potentially affect growth, retention, stemming back to trust? As I mentioned, patients will consume more resources than they need to when they are undiagnosed. Legal and financial risks. Failure to diagnose is considered a very serious medical error, and there is a huge percentage of medical malpractice lawsuits that are based off of being undiagnosed, because some people die before they get a diagnosis. And then, of course, we want to talk about patient satisfaction scores and how they trickle down into your reimbursement. That patient who got readmitted before 30 days, CMS is going to ding you. Those all factor into it. So when we see how patients feel when they feel heard and respected, both clinically and emotionally, they will trust your system. Most likely they will come back for future care. Better experience, better trust, better outcomes equal better reimbursement. A question to ponder: how does your system demonstrate trust? And it's not just one way. Again, it's very subjective on how patients view trust. Think about what it means to you. It means something different to somebody else. So how can Marcom help rebuild trust? From what I've heard from patients, not only on the podcast, but in the thousands of interviews I've conducted in market research, it's advocacy from both sides of the bedside, as I like to say. Patients need to do their part. Hospital systems need to do their part. Doctors need to do their part. How do we meet in the middle so patients get answers? So what they actually want. Patients want to be believed. They want a collaborative relationship or partnership. They just want the doctor to say sometimes, I don't know. I don't know. I think we appreciate that more than feeling like we're getting the runaround and getting passed along. And then really clear follow-ups. So what's next? Like my doctor said, I have no more bright ideas for you. What was I supposed to do? I had to figure it out. I became my own researcher, and this is when people go to Google. Dr. Google, as they say. Laura, my guest, she said in her episode, I Googled responsibly. For a patient to feel that she has to be careful about what she Googles and brings to her physician is stunning. Doctors are very turned off by the reams of paper that people will bring into their offices to talk about their diagnosis. But what are they supposed to do? If the doctor doesn't have any ideas, the patient has to advocate for themselves. She also said, on this one particular visit, Laura, I made sure that I dressed nice. I felt I had to dress really nice so that doctor would like me. And if that doctor liked me because I looked nice and I was presentable, he would take care of me. He would help me. What doctors wish patients would do. This is the other side of the bedside. Patients need to come in and prioritize what their top concerns are. If you're not prepared, and again, think about this just from your own perspectives. If you're not prepared and you have this whole story kind of swirling through your head and you're going through the whole timeline and timetable, keeping in mind that the doctors really only do have so much time, you may get only so far. Prioritize, bring the timeline of your symptoms, be open about medications, supplements, and the context in which you're taking them. Patients don't tell you everything, so be truthful. And do they have tools to even use to prepare for visits? What do patients have access to? We can't control the diagnostic journey. We're not the doctors. We're not the clinicians. Doctors will doctor the way they want to doctor. We can only control so much. But how can we help patients tell their health story and advocate for themselves? How can a system support self-advocacy? This is Nika. Nika is a pretty cool chick. She's a news writer in New York City. She is the one who was on my episode the title and her story is 36 procedures, 26 doctors, and a 30-year search to find answers. Eventually, she did get answers for a rare autoimmune disease called IgG4. And all the time she was trying to find an answer, going to doctor, and this is a mutation that causes benign tumors. She had tumors removed over and over and over again on all the different organs. Nobody could find the answer. She was seeing a rheumatologist. She saw a neurologist. She saw every ologist that you could imagine, and she'll talk to you about it on the episode. But it took one highly trained rheumatologist to say, oh, I've seen this. You have a rare condition, and I know what it is. She knew what it was before she even ran the test, and all it was a single blood test. But it came down to the skill and the experience of the physician. So let's hear from Nika.
I was not my own best advocate. I kind of took a passenger approach and let them be in the driver's seat. And I never took charge of my health. I used to hate that happy face chart where they would tell you what's your level of pain. Most times when I'd go to the doctor, they'd be rushing in and they'd look like they needed to rush out. So I never wanted to be the person to pick like the really sad face, even if I was in pain, because I thought I was becoming a nuisance. I was just kind of irritating them and interrupting their day. And so I never understood how important it was to be like, no, it's the middle dude. If I didn't like to complain, they go, how are you feeling? I would always answer, I'm okay, or it's not so bad, or it's not such a bad day. And always downplaying the symptoms. I'm complaining about what's wrong today, as opposed to, by the way, I've been feeling pretty crappy for the last few years.
So doctors work for us as patients. Pretend we're all patients here right now. They work for us. We're paying them for a service. She had to feel like she was imposing on the doctor. She didn't want to really talk about her symptoms, tell the truth about her symptoms, her truth about her health story. She was too worried about, well, the doctor might be too busy, might not want to hear my whole journey. She was protecting the doctor and his time versus worrying about her journey and her health. We heard from Charlene earlier. This is Dr. Colette Edwards. She is a board-certified internal medicine physician. And now she is the founder of a company called Positive Health, like menopause. So take a look at her sites, positivehealth.com. She started this amazing resource because she experienced so frequently that women who were in menopause were getting gaslit. Because there's about 200 different symptoms of menopause. That could be anything. And many times women get treated for a symptom of menopause as if it was a symptom of some other condition versus menopause.
I always go back to the importance of patients knowing as much as they can, taking as good care of themselves as they can, and advocating for themselves and asking questions and pushing the system. Because unless patients push the system, the things that need to change for everybody in the system, both on the patient side as well as the staff, as well as clinicians, is not going to happen because there's so many other forces that are in play that have resulted in the issues that we face every day.
To hear again from a physician that patients need to push the system to get answers is stunning and is recognized by our very own clinicians. This is very important from, again, patient experience and building trust. I can remember, I won't tell you which system I was working at the time, but I remember sitting in a conference room with all the marketers on the team, and it was a large team, and business development in front of the CEO of the system. And the CEO continued to ask us, are you a revenue generating department? And this was about the time when CRM was coming along and getting popular, data warehouse, all that stuff. And he did not believe that marketing was a revenue generating department. How many of you think you're a revenue generating department? Good. Yeah. Hard to prove sometimes though, right? Patient experience, in many ways, being a part of that, given that you have metrics for that. There are HCAP scores, there's press gainies, there's whatever other surveys you might be deploying now these days. But it's important to take a look at the bigger picture of patient experience program, because I look at this language issue, dismissive language, this gaslighting is a communication problem in many ways. Again, we can't control the diagnosis, and doctors will doctor the way they doctor, but there are some things as communicators that I believe we can help influence, maybe not control, but influence. So really taking a look at the bigger picture of your patient experience program. Bringing all the players to the table. It is a multidisciplinary program and approach. It's not just operations. It's not just, we saw yesterday from the Silver Cross presentation. Everyone walks a patient to a department or the elevator. Everyone is a part of that experience. Looking at those survey questions, are you asking questions about trust? Discussing feedbacks, identifying training needs, and looking at where the gaps are and the opportunities. And how do you brainstorm to fix and influence those low scoring areas and areas of opportunity? Couple of questions to ask about your patient experience program. What's the one small communication shift can you make to help patients think about your systems from a trust standpoint? Again, it's subjective depending on what it is, but how do you know? Wouldn't it be nice if you could improve care if providers and patients could find good communication the same way? Or understanding what trust means? And how well are the dots being connected between, say, marketing, clinicians, and operations so that the patient story doesn't get lost? And are we still working in silos? I remember talking about silos 20 years ago. How do you fix that? How do you share the responsibility for the patient experience? So a couple ways that, this is my one slide pitch, and how many of you have sat in meetings, brainstorming meetings at your system where you were so bored that you couldn't stand it? Yes. Just one? That's a tall hand, arm up there. Yes. Yes, I remember some brainstorming sessions, strategy sessions. I was the director of marketing in a few of the systems, AVP of advertising, and we'd bring the whole group together, and the service line directors, and everyone even from environmental services sometimes was sitting at the table. Let's brainstorm, let's solve our problems. Does anyone volunteer to be the first one to talk? Because of the voices in the room often are silenced because you know who the characters are in the meeting, who maybe said, oh, you think you know the answer? Nah. Let's bring in the big guys to tell us what we should be doing to solve our problems, and we'll spend a couple $100,000 to get the answers, when you all already have the answers. Again, my one slide pitch. I facilitate these strategy sessions in a way that everyone gets to talk. There is no judgment. And the people who live the experiences in their healthcare systems every day get to solve the problems. And when that happens, you all have buy-in. And you're not going back to the C-suite saying, yeah, but we told you that this was the solution. We told you that this was the answer. Who has that happened to here? I don't know. It happened to me so many times in the system. All the time. Yes, all the time. I facilitate strategy sessions, marketing brainstorming, operational issues, team building, and I use a variety of different methodologies, flip charts and sticky notes, those typical things I still use. But as you may have been wondering, why are there Legos on the table? I use a methodology called Lego Serious Play. Lego Serious Play is a methodology that, I'll use this word, democratizes the process for everyone to contribute. Now, wouldn't that be nice if everyone would get to contribute? Even your quietest employee associate talks. And the way it works is, and I don't always wear flamingo sunglasses in my sessions. Sometimes I do. But the goal of Lego Serious Play is that you're building your idea. You're creating your idea. So if somebody says, Karen, I need an idea for this, XYZ problem. Why is it patients don't understand that they should be going to immediate care instead of going to the emergency room for their cold, flu, whatever. I'm sure that's still an issue, even after 20 years. What do you think? And you could say, I think we need better communication around this, and that, so we can do a better job doing blah, blah, blah. Okay. Well, there might be other people in the room who aren't in PR who have a thought or an idea to contribute to this communication issue, but that's not their job necessarily. Everyone gets to talk. It's not the person who sits at the head of the table who says, I think we should be doing this. You all need to execute my idea. That is not what this process is about. Lego Serious Play is about speaking through metaphor. Build a model that explains what the gaps are in our patient experience program. Well, there's a disconnect, so maybe the model is a bridge from one corner to the other. Maybe it's that hair on fire Lego piece that everyone's running around with their hair on fire, and we can't fix this problem because no one knows what they're supposed to be doing. There's a disconnect on this position versus that position. It's an extremely effective problem-solving methodology that is baked in science, organizational development, and communication. I am a certified Lego Serious Play facilitator. There is a certification behind it. It's not just, hey, let's get together and play with bricks. Your CEs might think that initially, but that is not how it works. And when you build your model about what you feel the gap is in your patient experience program, or we don't understand what our positions are, everyone's overlapping, you speak through your model. The focus isn't on you. The focus is on the model. That's what makes for a judgment-free, democratized type of brainstorming process so that everyone gets to talk. So that is my pitch for Lego Serious Play. And you leave with a clear action plan. Wouldn't that be nice? Instead of everyone saying, okay, we have all these ideas on the stickies, now what do we do? Who's going to champion that? This process helps that. Some ideas for trust building messaging that I think as communicators we can think about. Can there be campaigns around you're not overreacting? You deserve answers. Can that be a message? Because everyone deserves answers. Promote switching providers and second opinions. There's so many physicians out there, and again, I've done these research interviews where doctors, for instance, a patient may have type 2 diabetes. The primary care physician wants to start the patient on first-line therapy, which is metformin, because that's what insurance allows. Until they fail that, then they could go on to more complicated, sophisticated medication, GLP-1. Doctors at certain levels don't know exactly how these medications work, but there are physicians that would sort of hang on to the patient because they don't want to lose that patient. They don't want to lose the revenue, and the patient keeps coming over and over again, and they're uncontrolled with their glucose. Finally, they get referred to an endocrinologist for more sophisticated, specialized care. Promote that second opinions are okay, and you are not offending your doctor if you do so. Are there branded checklists, journals, etc.? Are there any prep tools that maybe you're already offering that are baked into your EMR? I don't know what's going on in the EMR setting these days, but are we offering tools from a communicator standpoint? And make sure that you tell the whole story. Again, I think that there is an opportunity. It's not just about the best outcomes. It's not just about the fancy stuff. that you're getting in your ORs. New robots, new imaging, whatever it might be, rockstar doctor. There's this diagnostic journey that for so many patients is so important. And I think don't argue with me on this, but I think there's a way to talk about an interdisciplinary approach to helping a patient find a diagnosis. There is diagnostic medicine out there. Not all hospitals have those departments, but I think to show that from an interdisciplinary standpoint, cross-functional, however you want to put it, it's multifactorial in terms of how patients get diagnoses, and I think that there's an opportunity for that story out there. And then, very simply, craft trust and collaboration campaigns. Talk about how diagnosis is a two-way street, and how can you help patients be more prepared. This quote, as we wrap up here, experience isn't just a reflection of care, it's the new frontier of care delivery. The systems that will lead in the next decade are those that approach trust, communication, and consistency, not as soft skills, but as hard strategy. From the CEO of Press Gaming. Some final thoughts. Rethinking our roles as marketers and communicators, not just as the promotional department or that department that makes my brochure. It's about trust repair, trust building. And when people are dismissed, they don't just lose trust, they lose time, money, hope, and sometimes their lives because they give up. So be the system that patients trust. Be the voice that says, we believe you. And as I sign off on all of my podcast episodes, stay well and keep pushing for answers. Thank you, everyone. And again, it was a gift to be with all of you today.
It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozicka, a show dedicated to exploring the challenges of living with undiagnosed or rare medical conditions. This podcast explores both sides of the bedside. We will be speaking with patients who have had challenges with finding a diagnosis, along with experts in the field. I'm your host, Laura Nozicka. Please note I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur, and I am an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.